Hi, Angela. Give me a thumbs up or something if you can hear me. Just a couple minutes early, so I'm going to tag a few people. Hi, Charisse. Okay, we're going to start in about 30 seconds. So I've been struggling to get these things started on time, usually because of technical difficulties. So I wanted to go ahead and get started. Hey, Claudian. So thanks to all those that come on. Just talks amongst yourselves for a second. Not that that's really possible, but technology is cool, but kind of limits us sometimes. So let's go ahead and get started. Hey everyone, welcome. Hope you're having a great evening on this, if you're in the Northern Hemisphere, the last day of spring. Excited for summer to start tomorrow. So if everyone's excited for summer, go ahead and throw a hashtag summer in there. Hopefully you all have some great plans for summer. Hopefully you all have time that you're going to spend with family and do all kinds of things to kind of take the edge off and forget about some of your professional woes for a while. So as that may be, just let's move ahead. So like I said, today we're going to focus on skilled care. I know that and particularly so maintenance programs. And I know that there's a lot of confusion about that out there, especially when I talk directly with providers about it. So just a little bit of house cleaning. Again, thank you for being part of this group, Dark Secrets to Skilled Care. I really have enjoyed having an opportunity to kind of give a voice to some of the things that I do. A lot of providers don't get a chance to see what I see on a regular basis. And I wish I had, when I started working as a clinical reviewer, I had always wished that if I could just have, some providers watch over my shoulder to see what I see, especially on a national scale, I think it would change things a whole lot. I see some interesting things. So, and again, hopefully everyone can hear me. It said that my microphone was working. So if someone can give me a comment on letting me know that you can hear me, that would be helpful. But I'm going to keep on talking. I do want to encourage that you people ask me questions directly in the group. I love it when people do that. You have all seen Anthony do that, and I'm very thankful that he does that. I love being able to respond to those questions. So go ahead and keep doing so. All right, thanks, Claudian. You can do it in your personal Facebook page, and you can post me to the question, or just go ahead and post the question directly to the group. Or if you don't want to post it directly to the group, you can always message me. But it helps me come up with ways to address the group directly for the questions you have most immediately. I certainly have things that I want to talk about, but I can do them in whatever order. So whatever you guys want, that's what I'm going to try and present. So on to the subject for today, skilled care. First of all, I do want to make a little bit of a distinction here. A lot of times people think when we talk about skilled care, especially in the healthcare world, we're only talking about like a skilled nursing facility. And that's really not how it works in the case of what I do, especially for clinical review. Anything that is done to help rehabilitate or habilitate a patient is considered skilled care. So whether it's inpatient or outpatient, orthopedic or neurologic, that's all skilled care. And so everything we talk about today is going to go under that umbrella definition also. So please don't think that this is only a presentation for home health or skilled nursing facilities. This is for anybody that is going to be doing any kind of rehabilitation. And we are going to get into some Medicare particulars a little bit. So without further ado, what I'm going to start off with, and also go ahead and do, if you're watching this as a replay or live, however you want to do it, if you just want to throw in a hashtag live or replay, that just helps me know who's seeing what. So I appreciate that. First thing I want to talk about is Jimmo versus Sebelius. So if there is anybody that completely understands Jimmo versus Sebelius, I want you to put in the comments that you just understand it 100%. And I will turn the group over to you, and I will just step away because I know that that's an area that even myself, I don't understand it 100%, but I do have a certain level of understanding. And I know that a lot of people have some confusion with that as well. But that's where the skilled maintenance programs kind of all started. So January 24th, 2013, there was, there had been a long case of, Jimmo versus Sebelius. I don't even remember who they are. But it was basically, it was a lawsuit against providers that were, not providers, sorry, payers that were putting limitations, and more specifically Medicare, denying care to patients when they weren't making a functional progress. So providers were still saying that there was a need. Care was being terminated because the patients were no longer progressing. And so there was actually a settlement that came about January 24th, 2013, that indicated a continuation or need of care does not have to rely on functional progress, but on the need of the level of skill that is being given. Now, this settlement only applies to Medicare programs. The settlement did not arch over into private health plans or workers' comp or military health plans or anything of that nature. So for that instance, it is only going to refer to Medicare. However, over those years, there's been kind of some gray areas. There have been some private health plans also that will have a little bit of maintenance care written into their policies. Generally, that's for pediatrics, and I'm not going to go into those specific plans just because I don't know them all. I'd hate to miss one and mislead anybody, but some of those are out there. So from there, what has happened, Medicare has had to come up with programs to allow for this, and that is now generally what is called skilled maintenance programs. You may have also heard it as restorative nursing, and we're going to kind of talk about the difference of those. And hopefully this won't take very long. It is kind of a dry subject. And for those of you that may have seen the post, I have actually created a resource for you, and I've created a way that you can actually get it for free. It is a 4-page PDF, simple document that you can keep on your cell phone, your tablet. You can print it off, whatever. I'm going to give you access to that tonight. What I'll do is I'll actually put the link to where you can access that in the comments. To get it for free, you will actually need a coupon code. Because on my website, I do have it set up to where it would actually be a couple dollars to buy it. So if you would like the coupon code to the resource that I'm going to discuss, showing you the differences, and it does also show some information about Jimmo versus Sebelius, has great examples in it. Go ahead and please do hashtag PDF. Then I will message you that coupon code that will go. You can use that to the link that I'll put in the comments when we're done. Okay, great. Like I said, it's a little document that I kind of printed it out so I can use it for some of my notes. I'm not going to read it. We're just going to discuss it really quick. What we need to do is we need to also define skilled care. So This is something that has also been pretty, from what I've noticed in talking to providers, for many of you, you may, like I've mentioned, I do clinical review, which means I also do peer-to-peer calls. There is still this huge array of definitions of what people define as skilled care. There are several providers that just think as long as they give the care, that means it's skilled. You may have seen posts in the group about that recently. So really, skilled care, I'm going to approach it a little bit differently today in the way that I define it, because this is how I define it in the resource that you can get. I'm going to tell you what it's not, okay? So skilled care is not repetitive. Skilled care is not just checking boxes in exercise logs. Skilled care is not having a patient do the same exercises that they were given in a home program. Skilled care is not using functional measures. So giving care without actually measuring if there's some sort of functional deficit that patient may have. Let's see, what else? Skilled care is not for sports training, at least under most health plans. Because you have to remember, whoever's paying for it is kind of also defining what is going to be that skilled care. Skilled care is not care with goals that are not progressed, goals that are not measurable. Let's see. And also, if you have questions, comments, throw them in there, people. Skilled care is not continuing care just because a patient needs to use an assistive device. Skilled care is not care because a patient doesn't have access to a caregiver. That's another one, especially with Medicare. Just because a patient does not have a caregiver does not necessarily mean that they need to get your care. They need to be able to arrange for their own caregiver in some way, shape, or form, if that's the best way to deal with the situation. Okay. Skilled care is not reporting that a patient is at risk for falls and not having any numerical way of categorizing that. So no testing at all. You'd be surprised how often I see that. Skilled care is not continuing gait training and just going along with them for the ride when they can actually do it. I've seen people doing gait training that's like 500, 600, 1,000, 1,500 feet, and they're doing this all standby assist. That patient, how skilled is that you're just going on a stroll, you're walking in the park. So hopefully that kind of gives you an idea of what skilled care isn't, and that will help you understand more of what skilled care is. So now let's talk about reasonable and necessary. So skilled care also needs to be reasonable and necessary. In the handout that you'll get access to, hopefully everyone can still hear me. So I think the comments are really lagging behind today, or nobody put everybody to sleep already. So reasonable and necessary care is care that is based on published, peer-reviewed, strong research, clinical practice guidelines, and expert opinion. It needs to be specific to a disability or a functional problem. Or in the case of skilled maintenance care, we'll get into that in a minute. It needs to be a duration and frequency accepted under those same standards. So if the majority of your peers are going to see someone for maybe it's 6 visits and you're seeing them for 20 or 30 or 40, that's probably not going to be considered skilled care. More than likely there's something repetitive, there's something else going on there. It also indicates that a provider needs to be licensed. You need to be licensed to be giving that skilled care. Assistants need to be supervised. So that probably just gives you some ideas there. So what I want to do next is I'm going to go into some example. Well, let's talk about skilled maintenance programs. Okay, most of us know most of the care that we are doing is just traditional skilled rehabilitation care. The skilled maintenance program is a little bit of a different beast. Now, it's not that you don't do something different to qualify for it. It doesn't necessarily take up a whole bunch of different paperwork. What it is it's based on the way that you document and the way that your goals are set up. So to comply with Jimmo versus Sebelius, what needed to happen is if a patient stopped showing progress, functional progress, there needed to be a plan in place to help prevent them from having a really quick decline or continuing to injure themselves, hopefully to prevent them from just needing frequent medical care. So these programs, or these restorative nursing programs, maintenance skilled programs, this idea was created. And what it is it's skilled care, so reasonable and necessary. It's not repetitive. It's not all those other things we talked about. But you're using your skill to create a program. So this isn't continuous care. This isn't frequent care. It is a program that is carried out by the patient and whoever their caregivers are, family or staff if they're in assisted living. And then that program is carried out over time. Now, depending on the patient's status, at first it might be a visit every week, and then it's going to taper down and taper down even more. And it might get to the point to where that patient doesn't need an update for several months. Or maybe they start to show that they can now progress their function and they go back into traditional care. So it's just a way to keep these patients from just completely, falling off the edge of the earth, so to speak, in a rehab way. So that being said, it needs to be specific training to the patient and to caregivers. So if your patient has gotten to that point that they are no longer, and again, we're primarily talking about Medicare patients here. If they got to a point to where their function has plateaued, but you are fearful that they will continue to injure themselves or they will decline rapidly when they are discharged, then you can establish this program. And that's going to be based on your documentation and your goals. So it's going to be specific training to the patient and to the caregivers. So your documentation is going to talk about training caregivers, patient to do X, Y, and Z over X, Y, and Z amount of time to prevent X, Y, and Z decline or reduce of injury, all those things. And then the plan would be that you see them over, whenever that period of time has expired, and you progress from there. Again, it must be provided by a licensed professional. In the Medicare chapter 15, it talks about that it must be of a frequency and duration to appropriately train and address concerns with patient and caregiver. So these are going to be things that we're trying to train a caregiver to do. So it's not like you're not going to be saying, well, that caregiver needs to be giving them all kinds of mobilizations and manual therapy and all these things. That's not going to be appropriate. And so there's not going to be a need to see them on a real frequent basis. The Medicare also went to say that it's episodic care in nature. Sorry, I can't talk tonight. And it's not an ongoing basis, okay? And then some of the specific rules is that you must have sufficient documentation showing level of skill and the risks that the patients are, what risks are associated to that patient if they do not have that program in place that you want to establish, okay? In general, that's going to look like care that is a few times a month, on average, tapering down to once a month or less. Okay, so we talked about what skilled care is not. Let's talk about what a skilled maintenance program is not. Everyone's still out there? I'm seeing completely blankness on here. So it says Joey's here and Mandy's here and Emily, Dalton, Nib, Mike, Laura. So hopefully everyone is here. I'm going to keep plugging along. So what skilled maintenance programs are not? It is not frequent care for strength, for gait, for mobility, after functional measures have plateaued. It's not just continuing the same plan of care and the same goals that you previously had. So it's establishing new goals, and it's establishing, it's skilled care to establish that program. It's almost like a more intense home exercise program that's going to be carried out over a little bit more time, but it's just focusing on the training of the program. It is not keeping the goals the same and just calling it a restorative nursing program. You need to have, so let's back up. It's not having documentation that there is some kind of a risk involved for that patient. It's not continuing care for reasons of lack of specific equipment. So if a patient lacks things like a walker or bars, or because your clinic has parallel bars that they don't have at home, or your clinic has an FES bike that they don't have access to, that doesn't necessarily that doesn't just automatically qualify it as a skilled maintenance program just because of equipment. And again, same thing, it's not just because of a lack of an available caregiver. It is also not just the patient's family requesting that patient continue with skilled care. So those are some of the things that go into skilled rehabilitative care and skilled maintenance programs. I'm going to share an example here really quick, okay? So we have an 80-year-old male patient. He presents to therapy with a past history of weakness, dizziness, and recent falls. He has not had any recent care. He was previously independent with most daily tasks, but has become less active over the past few months. Functional assessment shows risks of falls through his Berg and tug scores. He had a recent minor fall with an injury about 3 months ago. So some things are pretty well established there. Goals, you go through the therapist goes through the eval and assessment. Goals are established to improve the Berg and the tug within MCID, as well as train the patient and his daughter in a home exercise program. Care is started at 2 to 3 times a week for 4 weeks. Over time, with help from his daughter, he becomes independent with a home exercise program. Care is reduced to 1 to 2 times a week over the next month. Patient improves his Berg score and his tug score. He's trained to use a cane. He's given an updated program with advice on progression. He's provided that at the end of the month. The provider recommends seeing the patient again in 2 to 3 months. So all of that I just gave, that whole story, that would be considered just skilled rehabilitation, okay? His goals are to improve in function. He did have some improved function up to a certain level. He was trained on his assistive device. His family was trained to help him with his home program that was based on improving his function. And then he was sent on his way when he had achieved that. Okay. The patient and daughter return after the several weeks. They report some parts of the home program are now simple, but he still has trouble in the dark and almost had a fall at night recently. The tug and berg are still about the same as when he was discharged. You decide to do some additional testing. You discover balance issues when the visual system is taxed. Time is spent updating the home program and training both on safe progressions. Provider recommends they return in another 3 weeks to see how things went. Okay, so there was a new risk that was established, but the patient was still doing their home program. They were still comfortable with it. The provider has now established there is a new risk, has created a new home program to focus on working on things in the dark. He could do that with his daughter, caregiver. So patient returns in another 3 weeks. He feels more confident in dark situations and can use the tips. He's used night lights, etc. Has been getting out of the house more, would like to use the senior center facilities to work out. Provider updates this program, gives education on workout progressions, recommends other community services. No other visits are scheduled. He used 2 visits over 6 weeks. Those 2 visits could be considered a skilled maintenance program. That program has been established. Now, if let's say he goes to that senior center facility, it's not appropriate for him, or he starts to decline, that program is already in place. The home program could then be adjusted if he came back in after several weeks. But hopefully that helps you give a little bit of a picture or a difference between what those 2 are. And again, if you have questions, throw them out there. I know this is a really complex, sometimes very confusing topic. So when you get that resource, again, be sure to do #PDF so that I can message you message you how to get that resource for free that I'm referencing. So, I mean, that's pretty much all I had planned for today. It's like I said, it's a gray area. It's a muddy area. It can be really hard sometimes, even for myself at times. Sometimes, when patients or when providers explain how a patient is doing, it makes it. Sometimes it sounds like they're progressing, and so you're like, man. I mean, so it can be very hard, especially when these are real people that we're dealing with. So I totally understand it when it can be difficult. That's why I wanted to create this resource. So just to show you, I mean, I've got a table that breaks it all up, nice and simple, along with some additional examples. It references, whoa, I know you can't read that. It references where you can find this specifically in Medicare language, the specific rules to it. So if you need to know those specific rules, you can go look those up. I have those links. So yeah, I think that's pretty much it. One other thing I did want to present to the group, one other idea, is that I would like to help you get a better idea of how your documentation is coming along. So this was an idea that was kind of placed in my brain by a fellow group member, Katie. She had made a post a long time ago mentioning something like, I wish that someone like Aaron could take a look at my documentation. So I want to create a way to where if you would like to send an example of your documentation to me, that I would review it and then come live, or however, is the best way to do it. And, kind of go through a review on it, tell you what looks good, what looks bad, what could be improved. Obviously, we have a huge concern with HIPAA. So I need to think about how to make this go through. Obviously, you would need to be the one that redacts all of that information, names, dates, date of birth, any kind of identification, and then how that would be sent to me. More than likely, it would be utilizing some kind of like a spreadsheet or a table. You would fill in the information that I ask for, and then you send me that, so that you're not sending anything from your clinic at all. I would prefer to keep that separate, keep it safe, mainly to keep you safe. So if that's something that you would be interested in, go ahead and post in the comments, just do a hashtag review. Then I'll know that there are some people that are interested. I'll probably do a post in the group about it too, but I just wanted to plant that seed in your head and see what you thought about that. So I apologize if this was really quick and really confusing. I know that it is. Sometimes I still even get confused with it. I have to go back to my resource. Like I said, I created this so that I could use it at work. I've added some things and made it even better so that when you guys look at it, you have the best information possible. So thank you so much for being here. Again, put in there, I will be linking to where you can find it on my website in the comments. And then to get the coupon code, be sure to do hashtag PDF, and I will send you that coupon code so you can get it completely free. It's a simple download. It's all it is. And then again, if you'd like the idea of seeing an actual review process on some of your documentation or what you're doing, do hashtag review, and that'll kind of give me an idea of how many people think that might be something they'd like to do. So have a great night. Thanks so much, and we'll talk to you later. Thanks, everybody. Bye.